Ronnie, I think the door probably automatically unlocks at this point.
Okay.
All right, so Drew White from Scripps Clinic, finally came up to rainy, cold Seattle. I don't know why you leave San Diego, but thank you for coming. We had a very enjoyable dinner last night on the roughly the same subject, but today with no commercial input, we're going to hear about elevated tryptase. What do you do next? So thank you.
That's great. Thanks. All right, thanks. It's great to be here in person. I think I did a Zoom talk during COVID, if I remember, to the group. So, it's my first time up in person. So thanks for the invitation. And as I shared last night, I developed an interest in the mast cell disorders maybe about 10 years ago. It was a little bit adjacent to some of my other research interests, but it's been a really fascinating disease, and there's a lot that we still don't understand about this. And I'm going to touch at the end on some of the issues related to mast cell activation syndrome that we see a lot in our practice. So not just focusing on clonal mastocytosis. Let's see if I can figure out how to make this advance. All right, there we go. Okay, so we'll talk a little bit about PET, because that comes up a lot when we're thinking about elevated tryptase levels. We'll talk a little bit about the differential diagnosis, but I'm mostly going to just sort of walk you through a case and something that we might see in this, and you can think about how you would approach this particular patient. So this is a hypothetical patient, 38-year-old female with recurrent flushing, widespread itching, frequent diarrhea. She sees her gastroenterologist, who is aware of this concept of MCAS, and so gets a tryptase. The tryptase comes back at 12.5. The normal range for most labs is 11.4, so it's elevated. It's super high, and because it's elevated, they're referred to you. So how are we going to work up this patient? So when I see a patient like this, I get referred this situation pretty often. I sit down with the patient, I try to help them understand, like, where are we going? And I put things into different categories. So the first thing I want to think about is this clonal or is it non-clonal? And we talked last night about the WHO criteria for mastocytosis. And so this is really the first thing that I think about is, could this patient have clonal mastocytosis? So here's the criteria. You need to have one major and one minor, or 3 minor. And the major criterion is going to be the accumulation of greater than 15 mast cells in these clusters, usually on bone marrow biopsy, but it can be on an extracutaneous organ. But skin doesn't count. Skin is sort of expected, and it would be cutaneous involvement. So you really need to show it somewhere else, but like a GI biopsy could also fulfill the criteria. And then your minor criteria are going to be abnormal morphology. So the mast cells have a spindle shape. I'll show you that in a second. The mast cells are going to have aberrant expression. And as we learned last night, some of these are markers that normally we see on T cells, but these CD2, CD25, CD30 not known to be expressed on mast cells at baseline. So when we see them, that's sign of aberrancy. The D16V allele mutation, and then the serum tryptase less than 20. So here's what you might see if you were a pathologist. What's that?
You said less than 20.
Greater than 20, sorry. Tryptase greater than 20. Thanks. So if you were a pathologist, this would be what you might see. So you could see the clustering on the upper left. These cells will stain for tryptase, which is in panel B. And then the spindling that you can see on the bottom left. And here is mast cells that are staining positive for CD25, which would also fulfill one of those minor criteria. Okay, so once you've gone down this path of mastocytosis, you've sent the patient for a biopsy, then you're going to stage the patient. Usually, if you're working with a hematologist, they're going to help assist with this. You're going to often end up with indolent systemic mastocytosis, or ISM. And I'm going to talk in a second about this concept of isolated bone marrow mastocytosis. It is not considered a distinct entity at this point. It is still just part of indolent systemic mastocytosis. There are some features that can make you classify the patient as smoldering systemic. So this is usually features associated with really high mast cell burden, but not actual frank organ failure. Once you have organ failure, so like ascites, or failure on losing 20% of your weight because you can't tolerate anything by mouth, those sorts of things, then you would be aggressive, which is down here. The other severe forms are going to be mastocytosis associated with another hematologic malignancy, and cell leukemia. And so basically, those three, the AHN, the ASN, MCL, those are going to primarily be managed with hematology oncology, whereas the top two are considered non-aggressive forms, and those are patients that often have cell mediator symptoms or recurrent anaphylaxis and tend to end up in our clinic. So we need to be aware of those. We were just talking about this a little bit beforehand, that this mutation, we think about this as just it's isolated to the mast cells. And in many cases that is, the higher up in the development pathway of mast cells, you might start to see same mutation in other cell lineages. And so in that situation, the KIT variant allele frequency will be high. Those patients may be harder to treat. And so the oncologists sometimes sort of think about this in terms of, well, this is also extending beyond the mast cell. The KIT mutation is seen in other cell lines. And there are other mutations or variants that are known to modify the severity of mastocytosis. And these are things that sometimes come up on next-gen sequencing. So with the hematologists will frequently order that as part of the panel, at least at our institution. And so sometimes those can be informative, and it's not for us, I think, to commit these to memory, but just to know that those exist. And in certain situations, it may be patient to know. All right, we talked a little bit about what happens with children last night. So, in children, cutaneous mastocytosis is sort of the normal way that they present. It usually resolves by puberty, whereas in adults, if they have cutaneous, they much more commonly also have systemic involvement. And it's always, I think, a little scary. I've only seen a few children with pretty widespread cutaneous mastocytosis, and so you worry a lot about, should I do a bone marrow biopsy, or how do I get the workup here? But for most of them, actually, it is really just isolated to cutaneous and doesn't extend. There's, for children, and you can't see this probably very well here, but there's the monomorphic form, which is the typical urticaria pigmentosa lesions that we see in adults. Whereas in children, there's also this polymorphic form. And the polymorphic form, as its name suggests, there's different, it's strictly delineated. Some of them are bigger, some of them are smaller. They have different morphologies. And that's the type that children have that tends to spontaneously resolve. This was a study that came out almost 10 years ago that just looked at the differences. If you're a child, you're more likely to have these polymorphic lesions, and they are more likely to resolve over time by puberty, whereas the more typical urticaria pigmentosa lesions, or the monomorphic form, if you have it in childhood, you're less likely to outgrow it. And I don't know if this is accurate, but the way that I think about this is, since this is sort of more of a typical adult presentation, that maybe why it doesn't spontaneously resolve, or is there something different about these polymorphic lesions that lends to them spontaneously resolving? Okay, so isolated bone marrow mastocytosis. This comes up. This comes up with patients that have severe venom anaphylaxis, and so you can imagine if you have a patient that comes to your clinic, needed epinephrine 3 times after a venom sting, and maybe he's a young man, and someone does a DEXA scan and has osteoporosis, that would be the patient that, in my opinion, needs a bone marrow biopsy, no matter what their baseline tryptase is, even if it's 4. So these would be the characteristics of this particular phenotype. So the patients tend to not have a lot of other symptoms. They don't tend to have cutaneous lesions. So the mastocytosis is really only going to be seen in the bone marrow. The features of these patients that really make them stand out are severe anaphylaxis and this unexplained osteoporosis. And the take-home point here is don't be dissuaded by a normal tryptase in that particular situation. I'll show you a slide to nail that point home here in a second. All right, so we're still talking about, this patient with a tryptase of 12. How do we work the patient up? Do we send them straight for bone marrow biopsy? So you don't necessarily need to do that right away. You have another tool, which is the high sensitivity c-Kit assay. Sorry, it's like a little cut off there, but I don't know how to move it. So this is a newer technique. Digital droplet PCR is the one that's commonly employed. And the way that this can be done is you can rapidly amplify the sample that you're analyzing, and so you're able to get a lot more sensitivity. So the older assays would have a sensitivity of maybe like 1% or somewhere in that range. And you see here the one listed has a sensitivity of 0.03% allelic frequency. So peripheral blood. In some studies, it's 100% specific, which makes sense. If you detect this, is almost certain that that patient has a mast cell clone that's D816V positive. And to be quite sensitive, 94% sensitive, but I put this other test or this study here on balance that if you looked just at patients with anaphylaxis and a tryptase of between 5 and 30, the negative predictive value was only 40%. So it probably depends a little bit on the patient population that you're using this in. Take home point is this is a great test if it's positive. If it's negative and you have a high suspicion, you may still want to move on to a bone marrow biopsy. So I mentioned how you can have this isolated bone marrow mastocytosis and have the patient present really with severe anaphylaxis, but still have a normal tryptase. That's what you see here. There's two studies that I'll share. They both come from an Eastern European country where the only center in the whole country that does venom skin testing and venom immunotherapy is one center. There's no referral bias. If you have a venom allergy, you go to this place, okay? They see everyone in the whole country. And so they've teamed up with some of the world's mastocytosis experts and then experts, because they can look at that entire population and get an idea of their differences in terms of severity without the confounder of referral bias. So this is a pretty, I think, sobering statistic here. If you look at patients that had grade 3, grade 4 anaphylaxis, in this group, they actually have a normal basal serum tryptase. Look at the percentage of patients that were KIT D816V positive that had grade 4 anaphylaxis. So 18% of them had c-KIT positive. And I would argue that that's really going to change your management. If nothing else, that patient will probably be on venom immunotherapy for life. It's super important to know, thinking about some of the other features that go with mastocytosis, like osteoporosis. We'll talk a little bit about, the other group that has an increased basal serum tryptase in a bit. The story is mostly the same. Worse your anaphylaxis is, you're far more likely to end up having mastocytosis.
That's positive from the digital droplet PCR.
Yes. Yeah.
Can I ask a trivial question? What's the abbreviation? Why do we call this c-Kit? Where does that term come from? What does that mean?
KIT's the receptor, and I don't know where the C comes from. Any idea? Anyone else? Robert?
I don't actually.
I'm not sure where the C comes from. All right, good question. So what are some other features? So you've got a patient like that I just shared at the beginning here. So a person with diarrhea and itching, maybe some flushing. Are there any scoring tools to help you decide? Because sending someone for a bone marrow biopsy is an insignificant event for a patient. They can sometimes be pretty resistant to it. So there's two scoring systems. These are not things that I think you necessarily are going to use clinically, or calculate the score necessarily, but they're more to think about the features of a patient when they tell you their story. And so you can see the things that give you more points and the things that take away points. So being male gives you a point. Actually having no itching, hives, or angioedema gives you a point. Whereas if you actually have angioedema, you're less likely to have mastocytosis because that tends to not be the presentation. And the other main feature of these patients is they'll get stung by a bee and they just go down, right? They have syncope, loss of consciousness, they're given epi, but they're missing a lot of the cutaneous features. And that's been seen multiple times. And so those are the things when you get that story, I think as allergists we're like, well, did you have hives? Because if you didn't have hives, it was probably vasovagal reaction. But we do need to figure that in. And then they looked at the basic tryptase level as well. So you could use that as a scoring system. NIH came up with a separate scoring system in 2018 that Melody put out. And basically what you see here is on the right, they added in, now that we have the high sensitivity PCR. So this was a slightly different technique, allele specific, the same general idea, high sensitivity PCR. And you add that in, and what you end up with is a much higher positive and negative predictive value. That sort of makes sense, right? You're using these clinical features, and then you're adding in this, and if it's negative, you're going to feel a lot more confident that you ruled it out, although not 100%. And then this is my last slide about mastocytosis. So just reminding you that we do now have a targeted treatment, avapritinib. What you see on the top is the improvement in symptoms, which was the primary endpoint that was looked at. Week 24 cutoff is where the red placebo group crossed over to open label extension. So these patients did have significant symptomatic improvement on the primary endpoint, and that benefit seemed to extend, at least for the patients that continued open label extension through week 48. The other feature that is important in their paper is the pretty dramatic improvement in skin lesions. I think that's hard to see here, but these patients will have pretty widespread cutaneous involvement, and you can see, even though this is not a primary endpoint, these are examples of before and after treatment with avapritinib. Okay, so let's come back to the patient. So patient gets a bone marrow biopsy in their right iliac crest. This is a patient with diarrhea, itching, and elevated tryptase. So normal mast cells, they're clustered, they're not spindled, there's no expression of CD25 or CD2 or CD30, D816V is not seen. You also had gotten a peripheral c-KIT mutation, which was normal. So the elevated tryptase is still unexplained. But the patient has symptoms, and that's not inconceivable to be related to some sort of mast cell problem, right? Diarrhea, itching. So, where do we go from here? So we'll just talk briefly about symptoms. So, Mastocytosis Society has come up with a few different surveys over the years, focused on the burden, the psychological and physical burden of mastocytosis. And you can see that, we'll go through this in detail, but that most patients, at least the patients, are going to have impairments in some aspects of their daily life and a significant psychological burden. And some of this is related to fear of these reactions, because patients may have experienced anaphylaxis once, and now they sort of have a little bit of PTSD about it, which makes sense. And then a lot of issues related to food and eating, because many of those things in our diet can be triggers for patients, and then the skin lesions themselves can be also disfiguring and a problem for patients. So lots of symptoms, lots of triggers, and these are sort of core exposures that humans have in life, right? So heat, stress, exercise, alcohol, medications, especially mast cell releaser medications like opiates and NSAID release. NSAIDs can do it. Odors can do it, which I think is fascinating, because we normally don't think of odors as really being a trigger for true mast cell activation, but it does seem to be a common trigger here for mastocytosis, and then insect stings. In the avapritinib trial, they focused on 11 symptoms in these domains. So we've got the GI symptoms, nausea, abdominal pain, and diarrhea. We've got fatigue and bone pain, which are can be very disabling for patients. And those are definitely symptoms that we don't track to just typical allergy, right? Mast cells, we don't think about causing bone pain or fatigue. It is something that is associated with mastocytosis. The dreaded brain fog, and then headache and dizziness, and then the cutaneous symptoms. All right, so what else can we do with the tryptase? So thinking of an elevated tryptase, one of the things that we can use tryptase for is to try to gauge mast cell activity. And so you could say, well, if the patient we're just talking about, was that tryptase elevated as part of symptoms, or was that their baseline serum tryptase when they were not having symptoms? And I think at this point, everyone's sort of familiar with this formula of 20% plus 2, right? And this came out of this idea that there's a huge range in tryptase. And so saying, well, we're going to say a cutoff of an increase in 4 points in tryptase is meaningful, but that doesn't apply if your baseline serum tryptase is 30 and it goes to 34. It's not necessarily going to be a huge change, whereas it would be if your baseline serum tryptase was 3. So the way that this formula would work, you can see listed here, is if your basal tryptase was 3, then you would mix 2, add 20%, and then add 2. And so if your basal tryptase was 3, above 5.6 would be significant for that. And if your basal tryptase was 150, likely because you have mastocytosis, then you would want to see it go up to 182. And this is important because you could argue, well, what if the patient went to the ER with something resembling anaphylaxis, and the ER doctor for the first time in their life orders a serum tryptase level, and you're looking at that patient back and it comes up at 7. And you're like, well, it's normal. But you actually don't quite know if that's normal, because what if their basal serum tryptase is 2? Well, now that's actually potentially represented a significant elevation. And I'm trying to move this out of the way. We had height floating heels. Okay. So when John Lyons was at NIH, he spent some more time thinking about this. At 20% plus 2, the benefit is that it has a high sensitivity, but a lower specificity. And so you can be careful with how you use that and how you're going to determine whether that event was mast cell mediated or not. So they came up with a different formula. And in this formula, you basically would multiply the basal tryptase by 1.685, and that improves the specificity. And there's actually a tryptase calculator on the NIAID website. If you're interested, they purposely spelled it incorrectly, so it's easy to find. So TRIPTASE. Does anyone ever use this? So you can put in your baseline tryptase, then you put in the acute tryptase, and then you can actually also dial in your clinical suspicion. And so they have different cutoffs. So the 68.5% is sort of the baseline, but if you have a very high suspicion, then it will give you the lower and the higher bounds of that. I think you can imagine situations where there's some dilemma about whether this event is really mast cell mediated and you're not quite sure, and then you have your own suspicion, you can put it in there. So I think that this is helpful as we think about how to use our serum tryptase. All right, so you talk about the negative workup this far for the patient. That their tryptase is a little bit out of range. So now you're going to think about hereditary alpha-tryptasemia, and the patient asks you, what are you going to do with that information? So now we'll talk about HAT. So if you look at the ranges of tryptase, you can see that average, if you see the line, it's systemic mastocytosis, sort of right around 30. For HAT, the average is going to be around 15, and then while that we pull the population out of the normal wild type, the actual normal range for tryptase might be closer to 4 for wild type, but you can see these huge range, right? And this huge clustering where it is going to be pretty difficult just based on the tryptase to tell the difference between mastocytosis and HAT. And even in HAT, you can have think the record now is 10 duplications, and each duplication is probably going to add about typically 10 to your basal serum tryptase. And so you can end up with these super high tryptase levels, even in cats. Because normally, I would think if someone came to me with a tryptase of 100, no chance this is happening. But it actually could be. And we'll talk about, you can have both.
The number 11.4 that we look at all the time, has that had the hat population removed?
No.
No.
So, Thermo Fisher makes one or all of the assays. I'm not sure. They actually make the one at our hospital, and it's interesting because without anyone telling me, hospitals switched the normal range to less than 8.4 3 years ago, and all of a sudden I was like getting all these abnormal tryptases that were like 9. And so I called the lab and they said, well, Thermo Fisher has changed the reference range to less than 8.4. That's what the packaging says. And AREP actually uses the same assay that also says 8.4, but they've kept it at 11.4. So I pitched to them and they're like, well, we don't think that this is a good cutoff. We're keeping it at 11.4. So we actually did a study just to see, does it change referral patterns? Do we find any more mast cell disorders with this lower cutoff? And didn't at all. I think the take home point is that it doesn't, sort of recognizing that there's probably a lot of normal individuals who happen to have HAT in there. And so 11.4 is still sort of a relatively good cutoff. But you're right, it's not, there's an argument that we should change the reference range completely. Yeah. So hereditary alpha-tryptasemia has been out long. I don't think you're all pretty familiar. So this is autosomal dominant. It's going to be present in about 5% of Caucasians. And so if you think about that, there's more than 20 people here in the room. So someone here probably has HAT. 20% of our patients that walk in the office with irritable bowel syndrome are going to have HAT. It's going to be, we have to factor that into every decision that we make and think about this. And it's a fascinating situation because you have the beta tryptase allele and then the alpha tryptase. And it's alpha tryptase that really controls the phenotype that we are seeing here. The patients will inherit an extra copy from one of their parents, and they also inherit the promoter. And so that's what drives the tryptase level to be significantly elevated. This is an easy test to get now. You can send it to gene by gene. They'll give you the genotype, the calculated genotype. And so you can at least confirm that the patient has that as an explanation for their elevated tryptase. All right, but what does it mean? So this was the first study that John Lyons did. It's been out there for quite a while that patients that had these high normal tryptase or high level tryptases without mastocytosis were different, right? There's higher rates of venom allergy if your tryptase is higher, regardless of whether you have mastocytosis. That's been known for quite some time. But they had this, big cohort of patients that had elevated tryptases that did not have mastocytosis, and when they went back, they saw all these signals for increase in venom reactions, increase in flushing and pruritus. Those make sense, but also some things that are, not what we would necessarily expect. So increased IBS, increased primary dentition. The Compass 31 is a symptom metric that looks at autonomic dysfunction, so sort of the POTS type of patient. And so they saw that connection, which I think, is really a big thing in our field to think about, are these things possibly connected? This was seen in a European cohort. Again, that there's a lot of wide-ranging symptoms that seems to be associated with HAT. So food intolerances, diarrhea, joint hypermobility, pain, flushing. This is what it might look like in a family, in a genotype, in a category, sorry. And so it shows you here, if we just focus on the patient here, we'll look at the family on the right. So the oldest patient there has a tryptase of 68, but is asymptomatic. Sorry, tryptase of 23, 68-year-old male, but is asymptomatic. And then their daughter has a tryptase of 12, has some of these features, maybe eczema, disease spells, and joint hypermobility. And then the child may be more significantly affected with mast cell type symptoms, with a lot of physical urticaria, flushing, and angioedema. But it's certainly common, and we see this a lot, where the family members have elevated tryptase, but may not be symptomatic, even though there is one particular individual that you think may be having mast cell symptoms. They also showed in their study that there was possibly a dose effect. So the more alpha copies that you had, the more likely you were to have those symptoms. And so this is just looking across the duplication versus triplication, and some of the things that stood out were increases in flushing and pruritus, reflux symptoms, these skeletal abnormalities like Tryptase abnormalities, and retained dentition. All right, so if there's a connection there, how can the tryptase be playing a role? So there's a couple studies. We're not going to go into them in detail, but really looking at how does tryptase function, because the alpha tryptase on its own as a monomer is really inert. It doesn't have significant biologic activity, but it forms these tetramers. And it seems that the composition of the tetramer with how much alphas and betas it has actually confers a lot of the biologic activity. So if you take a tetramer that's primarily betas, it has a lot less activity. And as you load or substitute more alphas into that tetramer, you're going to end up having more activity. And the theoretical areas that can have activity would be part 2. And part 2 has a lot of effects on paracellular permeability. And so they confer some of the anaphylaxis risk, because the patients are having more permeability. And then also the EMR2 receptor, which may be involved in mast cell vibratory sensing. And this was their study also that they did with John Lyons did with Larry Schwartz. And they showed that in patients with HAP, that almost all of them had vibratory urticaria, and that was also related to the amount of alpha tryptase. So the higher the alpha tryptase, the stronger that signal was for vibratory urticaria. And this is a very specific receptor that the alpha tryptase is thought to be acting through. It's the same receptor that is associated with the familial vibratory urticaria story that came out in New England Journal a couple of years ago. It's acting through that same receptor. Now, this is an interesting component of HAT, is that it's more common in mastocytosis. And that doesn't make any sense, because, autosomal dominant copy of alpha tryptase would not seem to cause any reason to have a secret mutation, later in life. So they seem like they should be unrelated to each other in terms of the physiology. Yet in multiple studies, the rate of HAT in mastocytosis is about 3 times higher than the background rate. So background rate is about 5% of Caucasian humans, and in mastocytosis, it's 15 to 18% of HAT. And these patients are also more symptomatic. And so if you look patients with mastocytosis and you follow down here, patients that have allergy problems, so either Hymenoptera or drug allergy, you can see that the rate was 36% of mastocytosis patients with versus 19% without. And then the same thing with mediator symptoms. So things like flushing, the skin symptoms, the cardiovascular symptoms, 71% of patients with HAT versus 42% women. So it seems pretty clear that having HAT modifies the phenotype of mastocytosis. It makes those patients potentially more symptomatic. And the argument that I hear is that the reason that it's higher in mastocytosis is just because they're more symptomatic. So they're coming to care. But to me, that I'm not satisfied with that explanation, because I feel like there's got to be more to it than just being more symptomatic. In any case, there's in every study that's been done, this signal of HAT in mastocytosis has stood up. And so it does make me think I should be testing for HAP even in mastocytosis patients because it may modify the phenotype. And even though you have an explanation in mastocytosis, you know why your tryptase is elevated, I know what you have about. Knowing about HAP actually can change that risk.
Does that mean they have two genetic mistakes? They have a KIT mutation and an extra copy of alpha-tryptase?
Exactly. Yes. Exactly. And actually, this just came up. I had a new patient came to me last week with severe anaphylaxis from SIN, who had new diagnosis of mastocytosis, and we're still figuring out staging her and everything. But I actually feel like I need to get that on her as well, just because she presented with very severe anaphylaxis from the SIN, and I feel like I want to understand if that's going to be part of her phenotype going forward and thinking about the risk. So this is just another study showing the same thing. If you're looking at patients that have venom allergy and severe cardiovascular mediator symptoms, a pretty strong association there with HAT. So having HAT increases the risk of those particular features. And this, it might not be able to see the color, but this is the exact same study I shared with you before, but now looking at HAT instead of mastocytosis. So same thing, this is that venom allergy center where every patient in the country with venom allergy goes to the same center. And here they're looking for, they also looked at mastocytosis over here, but in this group, what you can see is the same thing. If you look grade 1 versus grade 2 anaphylaxis, there's very little HAT in that group, just the normal background rate. As you go to grade 3 or grade 4 anaphylaxis, you start to see this enrichment for patients that have HAT. And if you look at the right here, the patients that had grade 4 anaphylaxis, that as if you factor in mastocytosis and HAT, so having HAT increases the risk, having mastocytosis increases the risk, which we know, and then there were actually some patients that had both, a small number of patients that had both, and those patients, all of them had grade 4 anaphylaxis.
Can I ask on that?
Sure.
This and the previous example you gave from the same center, is this specific to venom? Because you gave the example just a moment ago of a patient,
Yeah.
Moxin, grade 4 anaphylaxis. Should we be looking for this if you have that sort of severe anaphylaxis independent of the etiology? Because venom, I think about in this case working on a non-IgE mechanism. I don't know if that's correct or not. Whereas most everything else I can think of would work through an IgE mechanism. And should we?
So HAT severity has been associated with food allergy reactions. I'm not aware of for allergy or others, but I do think that the premise of presenting with severe anaphylaxis, because the thought is that this is more of a downstream effect on PAR and their permeability, that sort of any reason that you get anaphylaxis, if you have HAT, it could amplify the severity of it. So I agree. I think.
So, I mean, practically speaking, then do we do, HAT testing and digital droplet PCR in sort of anybody presenting with grade 4 anaphylaxis?
I would say yes, because grade 4 is pretty rare. I think grade 2, maybe not so much, but you can also get a tryptase because the HAT doesn't really exist at less than 6.5. If they have a baseline tryptase of 4, you don't have to worry about HAT. You just have to think about mastocytosis, and then low index of suspicion and their c-KIT's negative, you might be dead. But yeah, I think if you have that story of someone who's like, they needed like 2 epis and they were briefly pulseless, and I would say that patient probably warrants all of it. So this is their summary abstract for that paper where they looked at HAT being 5% of the general population, but being enriched for grade 4 honeybee anaphylaxis, causing increased symptoms and systemic mastocytosis, and there also being a signal for idiopathic anaphylaxis. With the theory here that this is really a effect of the increased alpha content of these tetramers that have better activity on PAR2, it can cause some increased vascular leak. I threw this study in here. It's a couple years old now. I've been really interested to see if anything else comes out of this. You know, a lot of these patients we see have a lot of GI symptoms, and they may have HAT, and it's impossible sometimes to tell, like, are those things connected? You know, HAT's relatively common. IBS is pretty common. I do have patients that have had a lot of improvement with, you know, mast cell mediator therapy, making me wonder. So this was a study that did biopsies, and they had control patients, and then they took patients that had and IBS phenotype, and then patients that had Crohn's, and they looked at Crohn's in remission, and they looked at something called pyroptosis, which is a cell death that's caspase 1 mediated, so it's sort of an inflammatory cell death. And something that I think you would see going, you know, gangbusters if you had active Crohn's. And basically what they showed in this study is that when you're looking at pyroptosis, patients that actually had IBS with HAT looked, when the pyroptosis assay actually looked sort of like they were approaching Crohn's patients as opposed to normal controls, you know, implying that maybe there's something going on in the gut apart from just normal, what we normally think about IBS. So I'm very interested, you know, for follow-on studies with this and to see if there's any sort of treatment that they do to see if that predicts anything. See if that's a real story. All right. What about HAT and dysautonomia? So that initial NIH study looked at increased compass scores. You know, there's a lot of stuff out there about POTS and the Titan score, which is a measure of joint hypermobility. We know that many HAT patients are asymptomatic. And so what really is a confounder is if every POTS patient with HAT, which is going to be 5% of POTS patients, comes to the allergist wanting us to treat their POTS, right? And it's sort of a, I mean, I see this all the time. It's a bit of a dilemma. They have an elevated tryptase that warrants being worked up and figuring out what's going on with it. But we also know at the end of the day, those two things might not necessarily be connected, and treatment might not really help them. This was a study, it just came out, I think last month that we did. So we have a big POTS cohort that's yours. So we wanted to see, is HAT enriched in POTS like it is in Venom allergy? And the short answer is no, it's not. We weren't able to genotype every single person who had an elevated tryptase, but if you just use the argument that anyone with a tryptase over 8 could have had a population of was no different. Meaning it's 5% of patients with POTS have had it's not any increased risk. Now, whether it may modify the phenotype, I think is an interesting question, and we were not able to really look at that to see, you know, were there differences in their, you know, the level of positivity of their tilt table. This would, you know, make the argument that you do not need to get a screening tryptase level in patients with POTS, looking for HAT or thinking of HAT. This is a table that we put out in a review article and checking this a few years ago, and just thinking about, you know, how do you factor in when to do some of this testing? And so, you know, their first sign is that when there are red flags present, is a patient with cytopenia, you know, hepatomegaly, obvious skin lesions consistent with mastocytosis, then you're just going to go down the funnel way no matter what. If their tryptase is less than 8, it's very unlikely that they have HAT, and you know, you could consider it if there's a strong family history and their tryptase is greater than 6.5. I don't think there's been cases that have really been uncovered with a tryptase of less than 6.5. So the tryptase can really guide you there. And then on the other side, you could do the digital droplet PCR testing. There is some thought to whether or not you should also work up mastocytosis. So let's say the patient's tryptase is 40 and they have HAT, but they only have one copy. That one copy would raise their tryptase probably about 10. And so there's a little bit of a discrepancy there with a very high tryptase. And so you may still want to do a clonal workup to see if they also have mastocytosis. So that's what that means with the discordance. Put this in here just as you know, food for thought. So this was a study looking at treatment with Omalizumab for patients that had, with the idea that those patients are maybe having, an additional mast cell activation that could be treated by Omalizumab. And they did note that the patients had, many of these patients had improvement in symptoms. Some of them had improvement in symptoms outside of the skin, so like GI symptoms improvement. But this is not a controlled study. It's just one of the only, pieces of information that we have showing that at least in these patients in an uncontrolled manner, there does seem to be some possible improvement.
Where did this whole idea that mast cell disease and POTS and dysautonomia and Ehlers-Danlos syndrome were all tied together and became a thing in social media?
Yeah. Well, we'll just table that because I'll on slide in a second. Yeah. So this is like the front of what we see on a daily basis, right? Is that question. I'm going to skip this slide for now. The take home point here is that you can actually still have HAT, but come back with a normal genotype. And you would know that because another family member would have an elevated tryptase and that patient may have HAT. You can actually have a beta loss, and so the calculated phenotype would be normal. They actually have a duplicated alpha. There's a paper on that if you're interested in it. I'm not going to spend more time, so we can talk about this. All right, so it's a common genetic condition or trait. I can use that one when I'm speaking with patients. It's not necessarily having HAT is not a problem. When it's symptomatic, there does seem to be this overlap with these, maybe joint complaints and connective tissue diseases and maybe some autonomic stuff, but very difficult to tease that out. It's not synonymous with these, and we'll talk in a second about sort of how do you pull out the question of MCAS. And the biggest thing is that these really need independent evaluation. As allergists, we're not necessarily going to be able to diagnose or rule in or rule out EDS or POTS. And I think the way, is best to think about this is that HAT can probably modify diseases, right? HAT does not cause mastocytosis that we think, and it modifies it. It doesn't cause venom allergy, but it modifies it. And so if you have POTS or connected, mast cell activation syndrome, then HAT may modify it. So I'm much more strict with that when patients come in and we diagnose this as like, this is a trait that you have. This is not a condition that we need to treat necessarily. So why does it matter to test? The patient initially said, like, what are we going to get with that information? So I think in some situations, it's actually important, like for venom anaphylaxis, mastocytosis we talked about, not forms of anaphylaxis. I think that's a reasonable reason to get it as well. I think we don't know and quite understand, but if patients have cell type of symptoms, they may benefit from certain empiric symptom relievers like antihistamines or hormones. For some patients, they've sort of been on this circuit of trying to figure out why their tryptase is high, and I think just closing the loop and saying this is why, this is what it is, can be helpful. And then in the future, I'll be interested to see, are there other phenotypes like what that group showed on the GI biopsy? So hopefully we'll come on that. All right, so this is the day-to-day for us, right? Is MCAS. What is it? So on the left, you've got sort of the classic symptoms, and these are the same symptoms that have come up throughout the whole talk. We see the mastocytosis, typical symptoms we're comfortable with as allergists. And then you have every other symptom known to man on the right that are not specific, right? And this is what's out in social media in terms of things. If you have unexplained brain fog, then that equals cell activation syndrome. So this is the first step, is thinking this through. And obviously, as allergists, we have a very different take on this than a lot of alternative providers or voices in the social media space. There's a big differential diagnosis, and I've actually diagnosed patients with other conditions. They come to see me convinced they have MCAS, and we end up after 6 months figuring out you have something else going on. I had one patient with thyrotoxicosis, right? And how horrible it is to just continue to be told that you have MCAS when you have something else that's much more treatable. And for us as internists, I think we have some level of comfort about thinking, like, let's take a step back here and think of other causes of flushing or other causes of diarrhea. So the definition here really requires these three things. So we want symptoms that match. So those would be the symptoms that I have mentioned, not necessarily things like, and brain fog that would meet the definition. You also sort of want this circular loop. You want to know that the mast cell treatments are helpful. So like H1 inhibitors and chromosomes and things like that. And then you want to know that there's evidence of cell activation. So you can use the tryptase calculator we talked about, and then we have these urine measurements, generally done as a 24-hour urine, N-methylhistamine, leukotriene E4, and PGF2 alpha. And these are relatively stable mediators that are predominantly produced by mast cells. It's not specific necessarily for mast cell activation syndrome, and have mostly just been validated in mastocytosis. This is what you might use those mediator measurements for. So that you've got a patient, they have a baseline elevated tryptase, they have these episodes of abdominal cramping and diarrhea, and you're not sure, is this mast cell mediated or is there something else going on? And you see that in this situation, getting tryptase is really helpful because you see it's elevated when they have these attacks, it goes down when they're asymptomatic. So you're going to be a lot more confident of approaching those symptoms as mast cell mediated as opposed to some other etiology. This was one of the first studies. I think this came out of Brigham with Rihanna and Matt Hamilton, and they just looked at patients that they've been diagnosing with MCAS and what were the dominant symptoms. And so you see GI and skin are really going to be the most common, but there are some of these other symptoms like the headache and poor concentration. It's hard to really wrap our minds around exactly what's going on with those symptoms. Predominantly these are symptoms that fit in our wheelhouse as allergists. So this is, I think, one of the first places that this POTS and mast cell activation syndrome story came from. This is a paper from Vanderbilt. Vanderbilt has a very big autonomic center. It's very well run, and they had noticed that in their POTS patients that there were a group of patients with POTS that would get bright red flushing and seem to respond to antihistamines. So they actually had those patients do urine histamine measurements during the attack. And they showed in this paper that patients that had elevated histamine had their flushing turn off by taking antihistamines. But there was also a group of patients that flushed, their histamine didn't go up, and those patients didn't get better. So this, raised the question that histamine could be involved here. And the authors sort of put this hypothesis there that you could have mast cells involved in the vasodilation, which makes sense. And then the patients have an inappropriate sympathetic response. So they end up driving in this circle, and potentially the mast cell could be involved in that circuit. So I think this is sort of where it came from. And then, you can understand why they would say, well, let's try antihistamines. It makes sense, right? And so then it just sort of explodes as, well, everyone should go on antihistamines and everyone with POTS has MCAS. So when we're getting these urine measurements, though, it's a challenge, I think, to interpret these. And there's not a really well-established range for what's considered abnormal. You've got a baseline level that we should probably be getting in our patients, and then you're getting a reaction urine. Just getting baseline 24-hour urine when the patient's not having symptoms isn't really particularly helpful. And I see that all the time. They come in with these numbers that they got at baseline and they're normal. Like, well, that doesn't tell us really a whole lot. We want to try to identify, what are the reactions that you're experiencing? And this is a study that Joe Butterfield at Mayo did, looking at urine measurements in mastocytosis when they reacted. So it's a little different. These patients were having like 10 to 100-fold increase in their mediator measurements. So this is not subtle, right? So when we see a patient that comes in and their histamine level is 10 points above the upper limit of normal, it's probably really not what we're talking about with an abnormal value. We're talking about fold increases associated with symptoms. And it may be more muted in patients with MCAS, but still, we should be seeing significant increases, and some of the recommendations are a threefold increase over baseline. All right. So my final sort of editorializing is, I think patients sort of come in with this idea of, I think I'll have MCAS, and then I'm trying to understand, like, what do you mean when you say the word, what do you mean? And, many of them are really high autonomic dysfunction, long COVID or chronic fatigue, and they have reactivity as part of that. And I really think that's just a different problem than MCAS that we're treating now, which are these distinct episodes of reactivity. And it's understandable where they can intersect. I don't really fault the patient for the confusion, right? Because they're having a lot of symptoms and they have a lot of reactivity. But I think we probably need to, as a field, come up with a different name so that we're not calling it all the same thing, because that would be helpful. This is not helpful. I pulled this off of a website. So research estimates that 17 to 20% of the US population has MCAS, which means 1 out of every 6 people, right? So this is what we combat with patients that come in, because they're being told this, and they have much better websites than we do. And so we end up having to push back on this. But at the same time, I commiserate with these patients because they really are struggling. Many of them, a lot of them are young. They're sort of in the prime of their life, and they're missing out on years of their life. This was a paper that just came out. If you're interested in this topic, you should check it out. Marcus Shaker was, I think, the senior author on it, and they sort of were advocating for a compassionate approach to these patients and helping them sort of sort this out. Not all of you are going to want to do that, but you're going to have patients where I think you do you see that the patient's struggling and you want to try to offer some suggestions, and so you can sort of work through some of their symptoms and make a problem list and try to pull things out for them. Like, okay, you have chronic pain. We're going to, take that away from MCAS. That's not MCAS, but maybe there's some other ways to approach it. And I'm running out of time. There's a great article that looked at histamine challenges to disprove the low histamine diet, which is something that comes up a lot. And in green, the vast majority of these patients, the placebo-controlled histamine challenge, it was negative. But intriguingly, I think, and they don't comment on this, there were a small number of patients that had objective signs like flushing with the histamine challenge, maybe suggesting that there's a small group in there that does have some histamine intolerance issues. Main message though, vast majority of these patients, it's not reproducible with the histamine challenge. So tell them to not go down that path. So, here's my summaries for the MCAS. We definitely need more crosstalk. If you see these patients and they're challenging, and you often need to have neurology and cardiology and maybe GI on board, and that isn't always the case. Think lumping everything together and calling it all MCAS is completely not helpful. We need more phenotypes and types. We actually need some placebo-controlled trial to show that anything that we do actually helps in the long run. And then this is more a message for neurologists. Telling patients that they have MCAS is not helpful, because you're going to say that they need epinephrine, and then you're going to their polypharmacy. So I feel like part of my job is to sort of redirect and sort of give other explanations and help patients understand their symptoms might not necessarily be rooted in mast cell disorder. And that's it. I went 1 minute over, sorry. But if you have questions.
I think there's a question in the chat.
Good.
Okay, the question in the chat. Oh, I see it.
Great.
Thanks.
It is,
Any quick question?
There's a question in the chat.
Any in the chat?
oh no, what did I do?
What happens?
Oh, okay, here we go. Let's see here. Did I just cancel the meeting?
So.
Not to worry, that they heard
Okay.
what was important.
Sorry.
Technical difficulties.
If we're asked the question, I'm happy if you want to email me. So go ahead and ask my email. Yeah.
Question about the criteria for systemic mastocytosis. The major criteria mentioned GI biopsy, but I thought like you could find mast cells normally in the GI biopsy. Is it the aggregate specifically?
So yes, and many patients with MCAS want their mast cells integrated in their GI tract, because that's also sort of there as like you should get that done, and then they get 40 mast cells per field. it's all meaningless because we don't really know what the normal limit is.
Mhm.
So I only will ask for staining if we think that the patient has true mastocytosis. And then, yes, exactly, you're looking for clusters of mast cells and you're looking for the aberrancy in there. So you try to fulfill the same criteria. But just randomly doing this in like a patient who's getting an endoscopy with a normal tryptase who has POTS, who wants the mast cells counted, I don't necessarily think is helpful or necessary. Creates more problems because then they come back with a number of mast cells and they think having them is abnormal.
Yeah, I've had that a couple times where like they show me the biopsy results and it has mast cells in the GI tract. So, normal.
Totally.
So for your case, that you presented at the beginning, for someone who has a tryptase in the 12-ish range, that patient went to bone marrow biopsy. But how often do you do the gene by gene testing for someone in that, tryptase in the teens and then stop, right? Where
Yep.
you told us for some people who end up with mastocytosis, you still do a gene by gene. What about the reverse? How often do you go doing the bone marrow biopsy when someone was positive?
Yeah, that's a great question. So the tryptase level will definitely steer me. So tryptase in the low teens is much more likely to be had. And so I'll often do that first. And I will almost always get a c-KIT mutation when I'm seeing these patients as well. So usually they come to me with a tryptase, I'll repeat it, I'll get c-KIT, and I tell them we're going to do this gene by gene test. And if they're up for it, then once I get the c-KIT, if it's negative, I'll mail them the gene by gene.
And then
Sim stop. Yeah, if they have had, exactly. Because sometimes yeah, exactly. They don't have anaphylaxis.
When we order a virtual blood c-KIT, is it always that digital droplet PCR? Do we know? I mean, I've been ordering that for years, not sure where that existed. I assume you guys just send it immediately.
This goes to ARUP.
They run this.
Yeah, I think we were trying it last night. So ARUP, Mayo, Austin, LabCorp all do high sensitivity, right? So you're probably getting high sensitivity.
Yeah.
It should say it in the report.
Yeah, for a while.
Great.
Well, again, thanks
Thanks.
for traveling up here.
Yeah, thanks for inviting me. Great.
I'm not sure. They did.
Did you see the chat questions?
Oh, no.
You wanna read them?
You read it?
Read them. I can't see them.
No, we got.
It's about
now
stopping
some-
allergy medications and aspirin prior to 24-hour urine testing. Do you advise that for patients, or since you're getting urine testing during reactions, is that kind of a moot point, or what's your advice there?
Yeah, so the aspirin or NSAIDs will have a big effect on the PGF2 alpha, so I would definitely want to make sure they're not on that. And I think that's an important mediator because if they're flushing a lot, that could be PGD2 mediated, in which case you would want to on aspirin, which has some risks. So it's the main one that I stop. Don't normally stop any of the other medications. They wouldn't necessarily, at least theoretically, have a huge effect on the 24-hour urine measurements. The only other consideration is, we want them to be symptomatic. And so if they're completely controlled on medications, then they'll come off in a huge flare. But then also if they're completely controlled, then we'll be monitoring to do the test. So I usually just tell them, like, bring the jug home. If you have a big reaction, let's plug it and see what we get. And then if it's totally negative and I have a high suspicion, I might repeat it again later. And that came out of one of the papers that Mariana did, is that some of these patients only fulfilled their lab criteria after a couple of attempts at getting it. So if you have high suspicion, you might want to repeat it.
Thank you so much. Really appreciate your time.